How brilliant. Thank you very much for having me. So today we're going to talk about protocols for recycling, and many of you that see them
been on the rise in our population recently. It's a significant portion of what I do every day. I would say it makes up currently about 80 to 90% of my current caseload. Okay, so torticollis. These babies are shocked. Torticollis traditionally is a really old diagnosis, and it means twisted neck. Historically, it was a spasm of a specific muscle, the SCM. And so I'm kind of going to bounce back and forth between using torticollis and positional asymmetry, because I feel that the torticollis that we're seeing most prevalent today is a different brand than what we have seen in the past. Historically, we didn't really know why kids got torticollis, but recently we're leaning towards believing that it's more from in utero positioning, especially those last 6 weeks of gestation. There's not much room. And then some question marks filling the air with facial asymmetry related to that second stage of labor, forceps, delivery, birth trauma, possibly contributing, although the research is weakening that hypothesis. But current literature suggests at least, and this is kind of old data now, at least 1 in 6 infants has some sort of positional asymmetry or torticollis. That's a lot. I think it's probably, we're getting 2020 data here soon, and I think we're going to see it closer to like 1 in 5, if not 1 in 4. The reason I don't like calling it torticollis is because it's not so much a spasm of a specific muscle anymore. This picture here shows a classic ATNR reflex. Newborns are all driven by a lot of reflexes, as we all know. So when babies have a positional preference to look to one side, which is kind of the classic sign for any torticollis positional asymmetry, you can see that it drives an entire kinetic chain reaction down their whole body. What happens when a kid stays in this position, like parents start noticing that they only like turn to the right, you can see that it really impacts not only their head and neck, it impacts their shoulders, how they're moving their arms, how their rib cage and weight is shifted, their pelvis positioning, as well as their legs kicking, and all the way really down to their toe and foot position. I think this is a really important concept to get, because we notice the head and neck, but me as a PT and my colleagues, we treat not only the head and neck, but the entire body. So I feel like I'm overemphasizing, but this is not just a head and neck asymmetry. Why is there a rise in torticollis? We're not completely sure, but there is a very high correlation with the introduction of back to sleep. Back to sleep, now infants are spending about 18 hours a day as a newborn on their backs, where before they were spending that 18 hours a day on their tummies. So if you think about it, in order to breathe, when we were laying infants on their stomachs, they had to move out of those positional preferences that they found in utero and clear their head, stretch their body, work a little differently against gravity. Now we put babies on their backs to sleep and they breathe easy peasy, which big fan, but their bodies aren't quite ready for gravity. And so that gravity overcomes them, and they're trying to find that position of comfort in utero. And that's where they kind of are overcome by gravity and stay in that one position. So we introduced back to sleep, and then at the same time, technology came out with these fancy car seats that clip in and out. They clip into the stroller. Parents got busier. More and more parents are both working. So we came out with the lovely devices such as the rock and play, the bouncer seat, the swing, the Mamaroo, the Boppy lounger. So there's all these containers that we're putting babies in, because we're so terrified of letting them sleep on their tummies that we're just going to have them lounge all day on their backs. I always joke that my dad does the same thing. I was like, your recliner's the same thing. So this was a great study. It was actually done in Canada, kind of a while ago now, But it really broke down, why are we having this increase in positional asymmetries, plagiocephaly, torticollis? They're finding that over half those babies got tummy time less than 3 times a day. That's actually pretty common in stories I hear in my practice. Most families, I would say, are doing it maybe one, maybe. Parents notice that positional preference right away, that they're like, they always look like this. We've all got smartphones and we're taking kind of a few pictures of our babies, and I always have parents start swiping. I'm like, do your pictures all look the same? And they can usually say, yeah, from day one. Any time an infant has that positional preference, they have 4 times the odds of developing a positional preference that's like impacting their motor development. So that's torticollis and positional plagiocephaly. I thought this stat was incredible. That so does she. Supine sleeping had a 2.7 times odds of developing that plagiocephaly. That's without like any noted positional preference, but just having babies lay on their backs to sleep, 2.7 times just to develop a flat spot. So the evidence that we're finding is that we really need to focus on varying this baby's head position, and not even just their head, their body position during the day, because we still want them to sleep on their back. Most infants, so before they're developing that flat spot, they are having facial asymmetries. Those are kind of the first things that you can notice. And most infants born have some sort of facial asymmetries because they came out squished, just as we talked about before. The biggest, most common things that I see are an asymmetry in jaw angle, asymmetry in cheek fullness, or an asymmetry in eye shape. So that early shift in skull position can start here before you even see it in the back. So it's helpful to screen a newborn baby's head in the back, but let's look at their face. So, because they've got this asymmetry in their face, most common babies struggle with that early breastfeeding. It's very common for a child with any positional asymmetry to have a hard time with early breastfeeding and needing lactation support. The 2 big musculoskeletal things that I commonly see are jaw asymmetry, as you can see this little guy yawning, how he opens with a deviation to one side. That's going to really impact our ability to open efficiently and latch to transfer milk. The other thing, which I think is probably the most common of most newborns, is any jaw retraction. And so that's where their little bottom lip is tucked under their top lip. As you can see with that baby laying there, how their chin is kind of recessed. That really also impacts our ability to open our mouth and stick out our tongue. So a little anatomy check. Our jaw is basically a suspension bridge. It's just hanging there in space, connected by all these lovely muscles. So if we've got any sort of asymmetry in muscle tone or length imbalance, it can really impact how our jaw is sitting. So that's how we get a jaw shift or a jaw recession. As you can see this little infant here, if we stick our head back, you can't stick your tongue out as far. Everybody can try that. You stick your head up, stick your tongue out. Then tuck your chin and stick your head down and stick your tongue out. It comes out a lot farther. Now everybody just looked. Yeah, it's a cool party trick. So that jaw position and then that global head position really impacts that baby's ability to feed. So we're not looking just again at that head and tongue and jaw. We're looking at their whole body. So if their shoulders are pulled back, that's going to pull their head back, and then they're still not able to open and latch. So these are really important early things that I encourage you to pick up on with your patients, that if they're complaining of challenges with breastfeeding, look at what that baby's mouth and body are doing. If they've got a preference to look to one side and have a recessed jaw, I would really encourage checking if they're doing tummy time, but also that's something to really note, that they're at a high risk for any muscle imbalances. This is actually statistics from my own caseload over a 4-month period. I looked at 48 infants that I was treating for torticollis. 69% of those families, that's a lot, had reported current or previous feeding difficulties. 66 of those had worked or were working with a lactation consultant, and then 31% of those were post tongue-tied clip. I thought that was pretty impressive that over 2/3 of my patients had had feeding challenges. What was even more shocking was that 60% of them were referred, I started seeing at 9 to 13 weeks. So they had struggled with feeding for over 2 months before I even saw them. And even a higher percentage had forfeited breastfeeding by the time I saw them, for whatever reason. But I think it's amazing to me because often we pick up that protocol at that 2-month well child check. That's when parents are like, yep, they like to look to that side. But for 2 months, they've been learning bad behaviors and all these tips and tricks on how to feed, but we could have been working on that maybe day 1. So when do you refer them to me? The APTA, my organization, just came out with new clinical practice guidelines for torticollis management. And one of their big pushes was information to primary care, because you guys are the ones seeing them first. Anytime you note any functional asymmetry in an infant, it's a good idea to maybe get a PT referral. We as PTs would love to screen a baby and say, you're good. I have yet to do that. But a few things to note. If you have any noted tilt or rotation of the head, neck, or body. So if their head is fine, but maybe their rib cage is shifted, that's something to note. If they're holding their pelvis tip to one side, how you can get that ATNR, their hip hikes up, that's something to note. Any sort of decreased passive range of motion in their cervical spine. So if you turn their head to each side and one side it's not quite as easy as the other, definitely probably should get that checked out. Parents noting any difficulty feeding or nursing on one side. So we've talked kind of a lot about the breastfeeding stuff already. But the other thing that I hear a lot, especially from bottle-fed babies, is that parents will say, I feed them the bottle, but as soon as they get going, they like to come over here. And so they're feeding them in these funky positions. That's not normal. I don't eat like this. And so why would we expect a baby to eat like this? Okay? A really common one that parents have reported to me is that they note a baby preferring to mouth one hand more than the other, or they're worried about their hips because their legs aren't kicking evenly. So if we think of back to that ATNR reflex, how that one hip is hiked more, one leg tends to stay longer more often than the other leg. And so if their kicking's not symmetrical, that would be a good reason to refer. Also, on the rare case, sometimes some kids do get a mass or tight muscle of their SCM still, and obviously that's a great time to refer. The biggest thing is if you notice any structural asymmetries. So any of those facial asymmetries that we talked about before, asymmetry in cheek fullness, asymmetry in jaw, asymmetry in eye shape, any asymmetry in like forehead, that is a good idea, because what that tells me is that that baby's at a high risk for being stuck in a position. And so their face is already starting to change. If you note any plagiocephaly or brachiocephaly, so any head flattening, that is a good idea to send a referral, because that's a great tattletale. Even though they've got good range of motion, that's a tattletale that that baby is spending more time in one position than moving freely in all positions. More and more research is coming out that plagiocephaly does not and will not self-correct, okay? It does not just spontaneously resolve. It will not go away. Yes, sometimes we can do tummy time and it won't get worse, but it's not gonna go away. It's kind of basic physics. If you think about it, their head gets flat because they put pressure on that side, and so they get kind of a rounding on the other side. We have to round it out, or else it's just gonna continue to grow like this. So just to review. So plagiocephaly is the most common thing that we see with torticollis. Not only do you see the flattening on the back of the head, as you can see over there, it also causes an ear shift. So my favorite way to check head shape is by putting my fingers behind their ears, and I look top down, and then I look from the back. And if I feel like their ears are off, that's a good indicator that they've got a little bit of flattening. That's a great tip for doing on newborns before they've got that obvious plagiocephaly. Then they also will get a little bit of bossing on the forehead, and so one side of their forehead sticks out another. Again, you can just put your finger across their forehead, and if you feel like it's not symmetrical, they probably got a little bit of flattening. Brachycephaly is a little less common, but is what we like to call the car seat head or the rock and play head. That is the baby that's spending a lot of time on the back of their head. While they may not have a true preference to turn to one side, those babies are the ones that are more likely to tilt to one side because they're staying a lot of time in a container that's not letting them move side to side, and so they're kind of shifting over. Brachycephaly also does not tend to spontaneous resolve, and it's actually a trickier one to fix from a positioning standpoint. And so I encourage you, if you notice a child with getting a flat back of their head, to refer and also recommend doing some more positioning throughout the day. These two head shapes I'm really passionate about correcting because what we're finding is in these older kids that are coming to us 4, 5, 6, 7, 8, they're having a hard time fitting bike helmets. They don't fit a standard bike helmet. They're having a hard time wearing sporting helmets because their skull isn't symmetrical, and so it doesn't fit that standard equipment. I've even had 2 kids that can't get normal eyeglasses because their ears aren't aligned, and so they have to get these like customizations to their eyeglasses and sunglasses because of facial asymmetries. I know, I get really paranoid about my ears too. I see everybody checking out there. Okay, so you've noticed some asymmetry. This is the reason why it's so important to refer as soon as possible. This has been kind of repeated in several studies since I put this together, but as you can see, the therapeutic duration, so this is a child referred for torticollis. They did a pretty intensive monitoring of range of motion and tissue length, and they found that children referred less than 1 month of old, 1 month, only spent about a month and a half. And that's not every week therapy. That's just they were followed by their therapist for about a month and a half. But if we're looking at those kids that we are looking at those 3 to 6 months, they're signing up for 7 and a half months of therapy. That's a lot of therapy. And the reason is because a baby that's 2 weeks old has a lot less tricks than a baby that's 3 months old. That baby that's 3 months old has spent 3 months learning to move in a motor pattern only in one way. I tell all my families, it's not that your baby has a strong side or a weak side, your baby has one dance move. They can't dance to the other side, and that makes it really hard to do things like learning to sit up, to roll, to walk, to run, to jump, ride a bike. We need both sides of our body to do things. So I think it's really important that I'm driving home that early referral because we get a much more higher success rate. Parents, it's a lot easier to treat, so we get better parent buy-in on exercises and home programs. They're in therapy a lot less duration, which is awesome, especially because a lot of these parents are playing beat the clock on when they have to go back to work. When I see a kid, the worst of all is when I've got a baby, they come in and they're 3.5 months, and mom goes, I'm going back to work in 2 weeks. How can we fix this in 2 weeks? And I go, oh boy. So that's also been a huge factor in my clinic's practice also, is getting these kids in as soon as possible, because then that way we can set up for the whole family to have success with this. As you can see, we've had a few kids that come in after 1 because they're not yet walking or they're really tilting. So we want to see them young and early because then we can have a really great outcome. That's one of the reasons that I love treating torticollis, is because out of all the things we see these kids face, it's fixable. That's easy. So not only as a therapist are we looking at that head and neck range of motion, as we talked about, that whole dance move they've got going on, we're looking at functional symmetry with all positions and all movement. My discharge criteria usually is I want to see them achieve a new motor milestone independently and symmetrically. And so some kids, that's learning to roll over. I want to see them learn to roll over to their right and to their left equally on their own. That shows me that they're using both sides of their body. They're learning and exploring pretty evenly. It's important. We also look at like making sure that they're using their arms pretty symmetrically. A big one is that lateral head righting. So that's the tilt that you get from older kids. I call it my older baby brand of torticollis. So we want to make sure that they're able to right their head through gravity, which is a really important thing down the road for balance and movement through in and out of developmentally appropriate positions. So therapy is more than just cervical range of motion. A lot of times families I hear, they're like, they can turn both sides, they're good, right? And I'm like, well, we're only using one hand, or we're really good at only rolling to our right, but we've never tried going to our left on our own. Those kids are the ones that they call it good then, they come see us again in 6 months. So the biggest thing with torticollis is all about prevention. More and more, again, more research, especially Canada, they know what's up with their prenatal education. They're finding that we've got to not only drive home the back to sleep program, but we really need to educate families on the prone to play and what that looks like and how to do that throughout the day. I think more and more parents are, there's scary things out there about the rock and play, but I think we're gonna see more and more of those, of that information about using containers safely and wisely. But I think as we as healthcare providers can also frontline that on using them responsibly. I educate my families to use them as a timeout spot for themselves. If you've got a fussy baby and you need a break, which we all do, that's when we use the mama-roo. That's when we use the swing. That's when we use the car seat stroller. But if I've got a happy baby that I can set down and eat lunch, that baby's going in the pack and play on the floor or in their crib on a firm, flat surface. So I think just educating parents about the equipment that they're getting with their baby showers or after their baby is born is really, really, really important. I love this like proactive positioning pyramid. If this isn't like a nerdy therapy thing, I don't know what is. So the most amount of time a baby should spend is on their back to sleep, right? And then ideally, the least amount of time should be in that baby gear or those containers. Well, right now, the average infant, so let's look at a 2 to 4 week old, spends about 14 to 16 hours per day sleeping. So they should be on their back. But then that baby wakes up. What does mom and dad do with them? They hold that baby, as they should. But let's encourage parents to spend some time on their tummy with their awake baby instead of laying them on the play gym with the dangly things that everybody loves. I love this idea because it kind of breaks down like what they should be doing during their day. So in the morning when the baby's happy and not super fussy, that baby can spend some time laying on their sides or on their tummy or being held. And then as baby starts to get more tired throughout the day, baby can spend more time on their back in the play gym and or in the swing or mama-roo as they get fussier, okay? I think it's all about changing our habits on how we handle and hang out with our babies. It's a huge cultural shift. I work with babies all the time, especially grandmas are like, we use the swing, just put them in the swing. And it's like, well, let's get some floor play. Let's put them on their tummy. As we kind of touched on, it's so easy to put babies in containers. I think I liked all these little pictures because you can really see that babies aren't allowed to freely move and shift their weight side to side. They're kind of tucked in and contained and not allowed to explore and practice their movement. So educating families on how to use their containers throughout the day. The biggest thing that I hear all the time is that parents say, I don't even know how to do tummy time. They're terrified to put their newborn baby on their tummy, and then they're like, okay, I'm supposed to do it. How? If any of you have ever tried taking a newborn baby and just laying them on their belly, usually doesn't go well, because by the time they got there, they were parachuted down, and then they're startled, and then they cry. And so new parents are going, oh boy, I broke them, and they take them right out. There's actually studies found that healthcare providers, so that's nurses, you guys, me, everyone in contact with these families, demonstrating how to do tummy time significantly impacts the frequency that they do it at home. I've worked closely with the Lytle Center on doing pre-post weights prone, and like families, it builds their comfort with the position and understanding that it's okay for their baby to kind of wiggle and move. I've had some providers work on, like while they're talking to families, roll that baby over and we can hang out on their belly for a few minutes. Newborn babies actually tend to calm if you roll them onto their belly versus laying splayed on their back and they're stressed. That's one of my favorite demonstrations, and I think that would be a great thing for you guys to incorporate with them in your office, is showing them that it's not a scary thing. It's not a torture time, as some people like to believe. But newborn babies that practice tummy time from day one and are in that position, it's not unfamiliar, it's not scary, it's not going to startle them, and parents can feel more empowered to do it. So a newborn baby, we want to do some tummy time on the floor as we're able, but we can also, let's utilize that crib. The baby's sleeping in the bassinet by their bed, but they have this beautiful crib in their nursery. Let's use it. Let's put that baby in the crib while you're putting away laundry for a couple minutes or after diaper changes. I love doing tummy time on my lap. That's a great way, especially as a newborn, when we're just trying to get time spent in that. They're safe, they're contained. Grandma, grandpa can do it. They're holding that baby, but that baby is also getting a different position than just laying on their back. Chest to chest is an all-time favorite. That's a great one for all parents and everyone to do. It's great bonding. There's so much research on chest to chest. But the one thing that I encourage parents to do is to lay down. Everybody just reclines in their seat and look, we're doing tummy time. Well, that's not totally working against gravity. Babies will lift their heads more if you're inclined, but laying flat, lay in bed and put that baby on your chest. And I'm gonna mess with this. How much tummy time should a baby do? Studies have found that doing at least 80 minutes per day by 4 months significantly improves their sensory motor development. So this is kind of what I pitch to my families. So let's shoot for the stars here. Let's do 30 minutes a day by the time they're 1 month old. And that's actually pretty easy to do, because if we're doing, think about if we even do every single diaper change, and I've had a few families do some experiments for me. They do every single diaper change just during the daytime. Nighttime's for sleeping, but just during the daytime, they got like 45 minutes with a newborn. They're like, we're doing that a lot, and the baby's awake. 60 minutes by 2 months old, and then 90 minutes by 3 months old. The reason that I kind of stop at 3 months, because by then I expect a baby to start being able to roll from their back to their tummy, and guess what, parents? You don't have to count tummy time anymore because they're doing it themselves. It's so important to get that exposure. I also, we do have a form through Swedish for tummy time that I'm looking at my manager. I think everybody can order for their clinics, but it kind of talks about that newborn tummy time doesn't have to just be lifting their head. That it's all about just getting their tucked legs, getting comfort in that position. They're getting a lot of sensory input in that position. They're figuring out, where's my face? Where's my hands? That's how kids actually learn to use their hands, is by having pressure and weight through their hands. So tummy time, tummy time, tummy time. So this is just an example of what I use commonly with my patients. So I always say short, frequent bouts throughout the day. I'm not a fan of torture time. I don't set them down and set the timer. I'd like to just do short little bouts. So 1 to 2 minutes after diaper changes. If we're on the floor or they're hanging out with you on the couch, we can do side lying, which is my second favorite position besides tummy time, and then roll them back onto their tummy. You'll be amazed how much more time a kid can spend in tummy time if we do little bouts. If I were gonna go run a marathon, I'm not gonna go outside and run 26 miles today. I'm gonna gradually build up, just as we'd expect babies to do. The biggest thing that I want you guys to take away is that teaching parents to always, always, always roll their babies in and out of tummy time. That'll reduce that startle, that'll teach that baby that this is an okay, safe position, and help also developmentally teach some of that rolling. Infants are much less likely to be startled or surprised if we can give them that input, and so that way they're a part of knowing where they're going and what is happening. So, I know I went fast. So just to summarize, torticollis plagiocephaly has significantly increased with back to sleep. So we really, as providers, need to do a better job on educating our families on the second part of the back to sleep program was prone to play. And so we need to teach families how they can incorporate more diversity in their positions throughout the day. Catching those positional asymmetries or functional asymmetries early as possible, especially when they're impacting feeding, is a great time to refer to therapy. We know that earlier intervention and referral is critical for effective and short outcomes. It's incredible to see. I've got 2 kids right now that I started seeing at 3 and 5 days old, and that was probably 3-4 weeks ago, and we're just about done with therapy. It's awesome, and parents are like, this is great, now we're done, and we still have a couple months to hang out before we go back to work. The last thing is to make sure that you demonstrate to families how to do tummy time. I think, at least in my world, tummy time just makes sense. It's like, oh, just put them on their bellies, it's okay. I think we've instilled so much fear about putting them on their bellies that we are the ones that they trust, that we need to show them how to do this, okay? Thank you very much. I work at Swedish Pediatric Therapy. Got it all, yeah.